So I start all of my review PowerPoints with a list of video resources as well as the books that I found helpful when I was studying this stuff. So I've mentioned him before, but Dr. Preddy has a couple of good videos on YouTube that help with the upper limb muscles and their innervations, including the muscles in the hand. Their Anatomy Zone also has some good videos. Specifically here, I've listed the videos for major nerves in the area, as well as a video for the arteries in the hand and the wrist. So let's start with the bones. When it comes to the bones of the hand, you have to start by thinking about, okay, articulation of the bones. So we can see the two major bones of our forearm are our ulna and our radius. And I mention this here because when it comes to articulation with the upper limb, the elbow is a part of your ulna, and what ends up happening is that you get articulation between the humerus and the ulna. And then you have articulation between the radius and the ulna, both proximally and distally. But then you have articulation with the distal radius. It articulates with your carpal bones. So you can see here, the ulna doesn't actually articulate with your carpal bones. It's attached to them via ligaments, but it is your radius that's actually, when you're flexing and extending your wrist, that is the carpal bones moving with the distal radius. So speaking of your carpal bones, you have 8, and you're going to need to memorize all 8 of them. People come up with random mnemonics to try and remember the bones in order. When I was learning anatomy, we used the mnemonic, some lovers try positions that they can't handle. You should pick whatever mnemonic works for your brain. So using this mnemonic, you can see how we have, and I'll do this picture over here, how we have our scaphoid, our lunate, our triquetrum, our pisiform, and this is the proximal row of carpal bones. And then going distally, you have trapezium, trapezoid, capitate, and hamate with its hook. A thing I want to note about remembering the bones in that order is it goes from the thumb to the little finger, and then the thumb to the little finger, proximal row, and then distal row. So if they ask you what bone is medial and most distal, or on the distal row, but the most medial, you would think about, okay, what bones are on my distal row? And then which side is medial versus lateral? So the listing here I have of ossification timing. So I found this one online. Dr. Austin specifically has a list of ossification months that she wants y'all to know. Here it is. So make sure you have this ossification timing in your head, because they can ask you a question like, a 5-month-old child is brought into the pediatrician for a checkup. How many carpal bones would you expect to see ossified, like on an X-ray, something like that. So if it's a 5-month-old child, you can safely say that 2 of the carpal bones should have ossified by then, because no matter the sex of the child, capitate and hamate are usually ossified by that timing. So the next set of bones when it comes to the hand, and we're now moving distally. So we already talked about our carpal bones here. So next up are your metacarpals. So we start counting when it comes to these bones, starting at the thumb and then going medially. So the metacarpal for the thumb is number 1, index finger number 2, middle finger number 3, ring 4, and little finger number 5. So these are your metacarpals. When thinking about where these bones are, if you make a fist and you see like the indentation of your knuckles, you can actually like, that's the indentation of your metacarpals right there. Now, moving even more distally, we can talk about the phalanges. So these are actual bones of your fingers. Note how for digits 2 through 5, you have 3 phalanges for each digit, but for your thumb, you only have 2. So for your thumb, you have proximal and distal, but for digits 2 through 5, you have proximal, middle, and distal. So when it comes to the abbreviations, DIP, PIP, and sometimes MIP, it can be interchangeable. Usually when they use those abbreviations, they're talking about the joints. So your proximal interphalangeal joint and your distal interphalangeal joint, but sometimes you'll see them for like the bones themselves too. Just know that usually when you have like when they're talking about the PIP and the DIP, they're usually talking about the joints. So proximal interphalangeal joint, distal interphalangeal joint, your PIP and your DIP. Okay, we're gonna go through, skip over the review. Okay, I'm going to skip over the upper limb, so the wrist fractures, because I know we've talked about wrist fractures in the past. When it comes to your carpal bones, your scaphoid bone is the most frequently fractured carpal bone. This is an example of a Fuchs injury, so falling on your outstretched hand. The important point about when it comes to breaking your scaphoid bone is that you can actually, if you don't catch it, the person can have avascular necrosis of the bone. So how this works. If you're looking at the blood supply here, note that you have a branch coming off of your radial artery that's going and giving blood supply to like the carpal bones. I believe it's like the dorsal carpal branch. Well, one of those branches is going to send off a branch going towards scaphoid. However, if you look, it's in a sort of retrograde fashion. So there's just that one branch there. So if you break the bone, you've cut out, like it will end up damaging that vessel and it'll cut off blood supply to the rest of the bone. Well, a break in the scaphoid is easy to miss when it comes to looking at an x-ray. So for the most part, if you come in with a wrist, like you come in and say to the doctor, hey, I fell on my hand, it hurts a little bit. What do you think is wrong? Is it a sprain? Is it a break? And they can't obviously see that there's a break. Oftentimes they'll put your thumb and like they'll put you in a little mini splint, which basically stabilizes the bone. Even though they might not be able to see it on an x-ray because they'd much rather, they're more precautious and make it so that like this bone is stabilized and then it can heal properly and the blood flow can continue, versus they're like, oh, you just sprained your wrist, come back in like a couple of weeks, you'll be fine, like it'll heal. And then when you come back, because they didn't splint it, they do another x-ray and they find that, oh, now I can see an area of bone death. Like nobody wants that. Excuse me. So for the most part, and usually it only takes about 10 to 14 days for that to happen. So for the most part, if you give a history about, falling on your hand and it's still painful there, they'll most likely put your thumb in like a splint to stabilize it so that you don't lose this bone, because nobody wants like a person to lose bone. So here's some x-rays where you can actually obviously see scaphoid has been broken here, here, and here. So contrast that with your lunate carpal bone, which is the bone that's most often dislocated, and it's almost always dislocated anteriorly. So scaphoid, most commonly fractured carpal bone; lunate, most commonly dislocated carpal bone. Now, when it comes to hamate and its hook, so the hook of hamate, excuse me, you actually have your ulnar nerve and artery passing by the hook of hamate. So if you ever fracture the hook of hamate, there's a chance that you could damage the ulnar artery and nerve that are passing by that area. So just keep in mind if there's a person with or you have a question where the person has a fractured hamate, like the hook of hamate, it could be damage to the ulnar nerve or the ulnar artery. And recall that ulnar nerve here is going to go and innervate the intrinsic muscles of the hand. So you'll have like weakness of the hand, possibly a partial claw hand. So here is an x-ray showing a fracture of the hook of hamate. So another fracture that you can get in your hand is a boxer's fracture, which the name is ironic because oftentimes this is for people who aren't boxers, who are unskilled at punching. And so the question will have a scenario where a person punched a wall or they got into a bar fight and punched someone. And they ended up with a fracture of the fourth or fifth metacarpal, specifically the distal head of the metacarpal. Now, if you have a scenario where the patient comes in and they're a professional fighter and they said they threw a punch and they felt something break, that's more likely to be the second or the third metacarpal because they actually have correct form where they're throwing a punch. So the unprofessional, the unskilled person, their fist is not aligned with their wrist, and so it's slightly abducted, and that when you do that and you're throwing the punch, you're putting the pressure on that fourth and fifth metacarpal. Instead of having the fist be flat when it connects, it's going to hit more on the fourth or fifth metacarpal, and that's how you end up fracturing it. So most professionals, like they know flat fist, you spread the force out over those four metacarpals, you're less likely to break them. Versus unskilled, they're going to be slightly abducted and then hit mostly on the fourth and fifth, and you end up with a break. So here's a good x-ray showing that broken metacarpal right there. Okay. So now let's talk about the carpal tunnel. So for the carpal tunnel, the roof of your carpal tunnel is made from what's called the flexor retinaculum, versus the floor is actual carpal bones. So here's another picture, like another plate, and you can see here's your flexor retinaculum and the contents of your carpal tunnel. And then below this is going to be your carpal bones. So I love this cross section when talking about the carpal tunnel because it very obviously shows you a more 3D picture of what you're dealing with. So here's our flexor retinaculum coming across. And then here are our carpal bones. And then inside, this is our carpal tunnel. Now, you will need to memorize the 9 tendons and the 1 nerve that pass through your carpal tunnel. And I want to make note now because some people get confused about this. The flexor carpi radialis tendon, this is not in the carpal tunnel. Your carpal tunnel goes from here over to here. So it's just this area inside here. So 9 tendons, 1 nerve. The 1 nerve that passes through your carpal tunnel is your median nerve. This makes sense when we think about carpal tunnel syndrome and how you have weakness, pain, and paresthesia over your thumb, index, and middle finger. Well, remember that the median nerve in the hand is innervating the first 2 lumbricals. So that's a lumbrical on your index finger and the lumbrical on your middle finger, as well as the muscles of your thenar eminence for your thumb. You can get carpal tunnel syndrome from repetitive use injury, compression injury, and unfortunately, when you're pregnant, you're more likely to develop carpal tunnel just because you're in like an inflammatory state. So median nerve is the 1 nerve that goes through your carpal tunnel. Now for the 9 tendons, you have 1 solitary tendon coming from your flexor pollicis longus muscle, and it travels through the carpal tunnel here. just lateral and deep to your median nerve. The other two muscles that have tendons that pass through the carpal tunnel are your flexor digitorum profundus muscle, as well as your flexor digitorum superficialis muscle. Flexor digitorum profundus muscle, the tendons passing through have a simple arrangement. They're flat, nice and easy to remember. So profundus, the 4 tendons pass flatly through the carpal tunnel. So this is the tendon that's going to digit 2, digit 3, digit 4, and digit 5. As opposed to your flexor digitorum superficialis muscle, its 4 tendons are actually stacked 2 and 2. So you are going to need to memorize the configuration of these tendons. You have tendons 3 and 4 stacked on top of tendons 2 and 5. So this is the tendon going to digit 2, digit 3, the tendon going to digit 4, the tendon going to digit 2, and the tendon going to digit 5. The way that I remembered it when I was taking anatomy is 34/25. So tendon for digit 3, digit 4, digit 2, digit 5, 34/25. Okay.
Hey, Kristen,
Sure.
I have a quick question about the contents of
Go ahead.
the carpal tunnel. So I was doing a problem earlier that asked about the contents, and it said that the radial bursa is also included in the contents. I couldn't find a plate that helped me figure that out. Do you have one?
So, the radial bursa is this bursa that's going over flexor pollicis longus, as opposed to this larger bursa over the rest of the tendons. That's the ulnar bursa. And I think, is it labeled over here? Yeah. So if you look over here, you can see radial bursa for flexor pollicis longus versus ulnar bursa for the other 8 tendons. So they're just wrapped around those tendons. And if you, hold on, let me back up one more. There we go. If you look, they're actually showing you the bursa themselves here. So see how the tendon is surrounded in the sheath here? It has its own little like surrounding area. That's trying to show you the bursa that's surrounding the tendon. So that circle around the tendon, that's the radial bursa versus these big like areas around these tendons. That's the ulnar bursa.
Okay, so both radial and ulnar bursa are like they're wrapped around the tendons that are in the carpal tunnel.
Correct. If you look, here we go. If you look here, so this is in the carpal tunnel. These like blue things, those are like the circles that were going around the tendons.
Gotcha.
Oh, and you
Okay.
can sort of see it a little bit better over here. So going around those 8 versus this one. And then there's your flexor retinaculum.
All right. Thanks so much.
Sure, no problem. I know it can be confusing.
I have another question about the carpal tunnel.
Go ahead.
She had spoken about how the palmar branch of the median nerve does not go through the carpal tunnel. So I'm hoping if you can kind of differentiate like the role of the nerves that go through it and the nerves that don't, in case we get questions asked about like compression of the carpal tunnel, what part of the median nerve is affected and what part isn't, since not all of it goes through there.
So when I hear palmar branch of anything, I think superficial. So palmar branch of median nerve, I'm going to think about, oh, so it's going to be more superficial. So that's probably going to be cutaneous innervation.
Okay, thank you.
Sure. Let me see if I have a picture somewhere. There we go. So if you look up here, you can see here's median nerve, and then here's that palmar branch coming off, and it's actually superficial to that flexor retinaculum, and it's doing that cutaneous innervation. So palmar cutaneous branch. Okay. So skip through part. So I threw this picture in here. You don't need to memorize these, but I threw this picture in here just to make the point that your thumb is really awesome and it can move in all directions, almost pretty much 360 degrees. So like abduction, adduction, flexion and extension, opposition, and reposition. So opposition is literally your thumb being able to touch the tip of every finger. That's opposition, versus reposition is just your thumb bringing itself back into line with the other fingers. Okay, so cutaneous innervation of the hand. I know this can be confusing, so I'm going to try and give you some tricks to help you when it comes to cutaneous innervation of the hand. The first thing that helped me a lot when trying to memorize what nerve covers what skin or innervates what skin parts of the hand is memorizing that the fingertips are never radial nerve. The fingertips will always be either median nerve or ulnar nerve. Median nerve is in the gold here, ulnar nerve is in the blue. In both palmar and dorsal surfaces, you can see the fingertips are never radial nerve. That was number one. Number two, when it comes to splitting cutaneous innervation in the palm, the split is down the ring finger between your median nerve and your ulnar nerve. So split down the ring finger for cutaneous innervation, median nerve versus ulnar nerve. Once again, just as a reminder, radial nerve is never the fingertips, but radial nerve is going to give you cutaneous innervation on the back side of the hand. So if the ring finger is for the split on the palm side, I then remember that the middle finger is for the split on the dorsal side, on the posterior side. So it's at the middle finger that you have the split between ulnar cutaneous innervation and radial cutaneous innervation. And then the last bit that helped me when remembering cutaneous innervation for the hand is that radial nerve goes all the way up here on your thumb. It doesn't go to the fingertip, but it is a large portion of thumb innervation, cutaneous innervation, even coming around to the palmar side. So if they give you a scenario where a patient has lost sensation to the proximal portion of the thumb, as well as has some weakness and extension of the hand, you know that that's radial nerve, because radial nerve innervates the extensor muscles of the hand, as well as cutaneous innervation on this proximal portion of the thumb. One last note while we're still on this picture, because it is super helpful. I know we've talked about musculocutaneous nerve doing innervation of the anterior compartment of the proximal arm. Recall that its terminal branch is the lateral antebrachial cutaneous nerve. Well, you can see here, the lateral antebrachial cutaneous nerve gives you cutaneous innervation on the proximal forearm, going all the way to the wrist and creeping a little bit into the hand. So if you have weakness in flexion as well as loss of sensation on the lateral surface of the forearm, that's musculocutaneous nerve damage, which you might not associate with like the area near the hand, and yet it gives you this cutaneous nerve branch. Okay. So your thenar and your hypothenar eminence. Each of these areas has a grouping of 3 muscles. So when I learned them as the OAF muscles, OAF. So opponens, abductor, and flexor brevis. So your thenar eminence is for your thumb. Your hypothenar eminence is for your little finger. When you see it in names, thumb is going to be referred to as pollicis, and then your little finger is going to be referred to as digiti minimi. So for your thenar eminence, you have your opponens pollicis, your abductor pollicis brevis, and your flexor pollicis brevis. These are the three muscles of your thenar eminence. For your hypothenar eminence, you have your opponens digiti minimi, your abductor digiti minimi, and your flexor digiti minimi brevis. So that's the hypothenar eminence. The thenar eminence is innervated by a median nerve. The hypothenar eminence is innervated by ulnar nerve. There we go. So Dr. Austin has some really good Nutter plates showing these muscles in relationship to the superficial palmar arch, which is part of the blood supply of the hand, as well as the ulnar bursa, and then your ulnar nerve versus your median nerve. You can see here's the branch coming off of median nerve to give innervation to your thenar muscles versus the branch off of ulnar nerve giving innervation to your hypothenar muscles. And again, another picture showing all of that together. Okay. So we spoke about this a little bit before, but I want to make a note on bursa because they're another easy question to ask. So a bursa is a fluid-filled sac, and you have them all over your body. They're for cushioning and the reduction of friction, so you don't have as much wear and tear with tendons and muscles. So you can see here, there's a bursa surrounding these ligaments to digits 2 through 5, versus there's a bursa just around this solitary ligament. So this bursa is your ulnar bursa, versus this solitary bursa is your radial bursa. And this is the usual arrangement of the bursa in your hand. However, there is a common variation where the bursa have this passage in between them. So you can see how you can get fluid passing through all of them. So in this scenario, a person could theoretically cut their little finger, get an infection, and the infection spread from their little finger to their thumb via the fluid in these bursa. Okay.
I have
So
a quick question.
go ahead.
Sorry. So the next picture right next to it, it looks like it doesn't have the intermediate bursa. So does that mean if there's an infection of the thumb, there would less likely, yes, that one, would there be less likely an infection in the pinky because there's no intermediate bursa in between it, or is that just
No, that's correct.
too?
Yeah.
Okay,
So for this
perfect.
one, like the infection would come down, but there's no crossover between the bursa here.
Okay.
Wait, I thought she mentioned something about a horseshoe effect.
That's for this
Well, the
common
horseshoe effect is
variation. Yeah, for
yeah.
this one.
Wait, so also, oh, sorry.
No, go ahead.
Yeah, so I just want to clarify. So in both the usual arrangement and the common variation, so like if you do get an infection in the pinky, there'd be no way to get, for that infection to spread to fingers 2, 3, or 4.
So it would spread, so it could just not via the bursa. So you're like an infection in your body can spread like throughout your body via your soft tissues via your blood supply and stuff like that. It's just that if it's spreading, it's not because of the bursa.
Gotcha. Okay, thanks.
Sure. The next muscle of the hand that I want to mention, because we've talked about our thenar muscles, our hypothenar muscles. The next muscle I'm going to mention is your adductor pollicis. So adductor, adding the thumb to the hand. So action is adduction of the thumb. It originates on your third metacarpal and your capitate bone and then inserts on the thumb. You can see how it has a transverse head and an oblique head, and it's innervated by a deep branch of ulnar nerve. When it comes to innervations in the hand of the muscles, most of the muscles in the hand are innervated by ulnar nerve. Okay, so symmetry of your hand. So one of the things that I would do if it weren't for COVID is I would literally show you how I learned about the symmetry of the hand. And Dr. Preddy goes through this in his video, but you can see it just if you put your hand in front of your face and you simply open and close your fingers, but you stare at your middle finger, you'll notice that your middle finger really doesn't move that much. And that's because your middle finger is at the center of the hand. So if you're simply just opening and closing your fingers, like your middle finger just doesn't really move all that much. Versus if you're intentionally trying to move the middle finger, like you have to intentionally think about moving it. Well, since the middle finger is the middle of the hand, for symmetry, the middle finger at rest is adducted, versus when you're moving it, any movement of the middle finger is abduction because it is at the center of the hand. So this comes into play when we're thinking about our palmar interosseous muscles and our dorsal interosseous muscles. For our palmar interosseous and dorsal interosseous muscles, when I learned them, we had nicknamed them pads and dabs to help you remember that the palmar interossei adduct versus the dorsal interossei abduct. So pads, adduction, dabs, abduction. So since for adduction, you only need to move digits 2, 4, and 5, there's no palmar interossei attached to your middle finger because it's already at rest, adducted. Versus for abduction, your middle finger has 2 dorsal interossei because in whatever direction it moves, it's abducting from the center of the hand. Your thumb and your little finger do not have any dorsal interossei because remember from the thenar evidence, they both have their own abductors already. So you have your abductor digiti minimi and you have your abductor pollicis. Abductor pollicis brevis, there we go. Another thing of note when talking about your palmar versus your dorsal interossei, note that your palmar interossei have 1 muscle belly, but your dorsal interossei have 2 muscle bellies. So you can call your palmar interossei unipinnate, so 1 muscle belly, versus your dorsal interossei can be called bipinnate, 2 muscle bellies. Okay, so the next set of hand muscles we're going to talk about are your lumbricals. So you can see how you have 1, 2, 3, 4 lumbricals. And they all start out on tendons and then insert on the sides of the phalanges. And Dr. Preddy talks about how they're like your puppet muscles because they help you if you watch the video, he just like explains the action better, but yeah, they help flatten out your fingers and like bring them down, like help you to flex them. So here are your 4 lumbricals. Recall that lumbricals 1 and 2 are innervated by median nerve, but lumbricals 3 and 4 are innervated by ulnar nerve. And again, lumbricals 1 and 2 have 1 muscle belly, so they can be called unipinnate, versus lumbricals 3 and 4 have 2 muscle bellies, so they can be called bipinnate. And they originate from the tendons of your flexor digitorum profundus muscle. So this is just talking about how, like, this is the action, like trying to show some of the action of the lumbricals and how they help to flatten out your fingers. So when it comes to innervations of muscles in the hand, it is mostly ulnar nerve except for 1/2 loaf. 1/2 standing for your first and second, the L for lumbricals, so your first and second lumbricals. And then OAF, the 3 muscles of your thenar eminence for your thumb. These are innervated by median nerve. And then I threw in a chart for people who like charts. Okay. Muscles. Okay, she talks about anatomical snuff box and then she goes into blood supply. Okay. So before we start, before we go any further, I just want to make mention of a quirky little mnemonic that me and my classmates used to remember all of the different nerve damage and what you would see in your patient. So the mnemonic we use is Dr. Kumbasik. So as a side note, for all these mnemonics, you can either just remember them off the cuff, or sometimes when we would take a test, we would sit down and just automatically write out, as soon as the test would start, write out the mnemonic and then refer back to it when we would need it. So however you want to use these, or use them not at all, whatever way your brain works, just do that. But so the DR for the doctor part helped us remember wrist drop was caused by radial nerve. The CU, claw hand, ulnar nerve. MBA, so median nerve causes Benedictine attitude or ape hand. And then SE, superior trunk damage causes Herb Duchenne palsy. And then IK, inferior trunk damage causes clunky. So it just helped us, and hopefully it can help you. When you damage your ulnar nerve, you end up with claw hand. So claw hand happens when you've lost the intrinsic muscles of the hand. Notice how when looking at this hand, the fingers are flexed, but also extended. So the intrinsic muscles of the hand actually balance out the flexors and the extensors of the forearm. So when you lose those, you end up with this hand that is both flexed and extended at the same time. So that's claw hand. Median nerve, you can end up with what's called ape hand, which is the flattening out of your thenar eminence. So you're not able to oppose the thumb anymore because you've lost innervation to that thenar eminence. You can also end up with what's called hand of benediction. So in these patients, they come in and you ask them to make a fist. And when they make a fist, they're only able to curl in these last 2 fingers. Well, that's because they've lost median nerve innervation. So they're able to move these 2 fingers because ulnar nerve is allowing them to flex them, but they've lost median nerve. And then finally, wrist drop, you've lost extension, you've lost the extensors to the hand. So it's just at baseline, it's going to be flexed. Oh, can you hear me now? What was the last thing that you heard that was clear? Jayla, you said I was breaking up. Can you hear me now? Okay. What was the last thing that you heard that was clear? Oh, okay. All right. All right, well, then we'll just keep going. So the next clinical correlation that I wanted to mention, excuse me, is Dupuytren's contracture. So Dupuytren's contracture is a progressive fibrosis. So it's a thickening and a fibrosis of tendons of the hand that causes the fourth and fifth digit to become more flexed at baseline. So notice how this has a similar hand arrangement as hand of benediction. The important thing to note is this is the person's hand at rest. They're not trying to make a fist. It's because of the fibrosis and the shortening of these tendons that's pulling their fingers towards their hand, and they can't fully open up. They can't fully extend their fingers because of it. It's hereditary. They're not quite sure why it happens. In order to fix it, it usually requires surgery where they go in and they cut out fibrotic areas, they release the tendons, and then sew them up loosely in hopes that they'll heal and then be able to go back to a normal baseline hand. Okay. All right, so let's talk about blood supply in the hand. So the blood supply of the hand represents an anastomosis of your ulnar and radial arteries. The two big structures that are shown here in this picture are your superficial palmar arch, as well as your deep palmar arch. And both ulnar and radial artery give blood supply to both arches. Another important thing that I want to point out in this picture, because it's a good picture for it, even though they're not labeled. So notice how if you follow radial artery going distally, it gives off a branch towards that lateral side of the index finger. This blood vessel is called your radialis indicus artery. So literally like the index finger's radial artery, so radialis indicus. And it also gives off this branch going towards the thumb. It's your princeps pollicis artery, so the principal artery to the thumb, princeps pollicis. Another thing I want to note on this picture, because it's much easier to see it than other photos or other drawings. Your superficial palmar arch, as well as your deep palmar arch, both give off branches that come together as the common palmar arteries, I believe. And then, so they anastomose with themselves. So the arches represent an anastomosis of your ulnar and radial arteries. And then the arches themselves also anastomose here and then branch off as, I believe, proper digital arteries. And there's label pictures later that will show this. It's just that this one is so clear because I took away everything else except for like these major structures to make it easier for you to see. So superficial palmar arch. And then you can see coming together. So I put little stars by what I felt were the most important arteries that you guys should know here. So yeah. And then the deep palmar arch. So superficial arch, deep arch. And then here they are. Yep, these are your common palmar digital arteries. And then branching off into the proper palmar digital arteries. So all of this is on the palm side of the hand. On the dorsal side of the hand, when it comes to arterial blood supply, it gets a little bit interesting because you have the reemergence of anterior interosseous and posterior interosseous arteries. They didn't go away. They kept going down the forearm and then they came back together. So remember they branched off of common interosseous, which is a branch off of the ulnar nerve. ulnar artery more proximal in the arm. Well, they came down your forearm, re-anastomosed with each other, and then gave blood supply to the dorsal carpal arch. And then it's a whole bunch of clinical correlations that I pulled from Moore. I want to make sure I hit, oh, anatomical snuff box. Right, okay. Is that in this PowerPoint or is that in my upper limb PowerPoint? There it is, okay. So your anatomical snuff box, it is important that, hold on just one second. It is important that you memorize the boundaries of your anatomical snuff box, specifically these 3 tendons. So you have your extensor pollicis brevis, your extensor pollicis longus, and your abductor pollicis longus. All of them are considered boundaries of your anatomical snuff box. Note that in the floor, or deep in your anatomical snuff box, you actually have your scaphoid bone, your trapezium, and the proximal portion of your first metacarpal. Your radial artery passes through your anatomical snuff box. And I believe Dr. Austin has a list of things that she wants you to know about your anatomical snuff box. There we go. So, yep, radial nerve has a dorsal digital branch that passes through, which I believe is this guy right here. There's a cephalic vein branch that's cut away, but it also passes through. There's radial artery, scaphoid bone, trapezium, and base of the first metacarpal. So you got to know these contents of your snuff box, superficial to deep, because you can be quizzed on them. Okay. I think those were all of the big things from her PowerPoint. Okay. So I included a bunch of other clinical correlations on here. I don't know how important they'll be for y'all. I just know that like this was stuff that came up when I was studying the hand. So learning about mallet or baseball finger, where the example that they give is a person sliding into home base and they hit their finger and it causes a sudden severe tear, or excuse me, sudden severe tension that avulses part of the tendon off of the finger. So at baseline, like at rest, this is what the finger looks like because they've lost that tendon that was like for the tip of the finger for extension, versus the swan neck deformity, which you get from inflammation. So rheumatoid arthritis, from an injury or from a genetic disease, with the example being Ehlers-Danlos. So notice how you have flexion at the DIP with hyperextension at the PIP. So you can see how this is not normal, like this is not in line. And then this is superflex too. So there's the swan net that they're talking about. And this is a patient with like severe RA. And then anterior interosseous syndrome, which the anterior interosseous nerve is a branch off of median. And if you have damage to that nerve, when you ask a person to make an OK sign, instead of being able to flex the fingertip to get the tip of the index with the tip of the thumb, it'll be flat. So you end up with this pinch look instead of like the normal OK. And that's how you know you have damage to the anterior interosseous nerve. And then again, Dupuytren's contracture, which we mentioned before. And I don't think you guys need to know about it. Like I just threw in some other random stuff that I found. I think those are all of the big things. Okay. So it is 11:53. So I will stop sharing. Are there any questions as we are finishing up? And actually, I'll go ahead and stop recording as well.